观众们，大家好，欢迎收看本期的最佳方案。根据美国的医疗机构统计呢，在美国有1/3的中老年人都患有膝关节的疾病，这给人们生活带来很多的痛苦。今天呢，我们非常有幸地采访到了德州的休斯顿赫尔曼西南纪念医院关节治疗中心的主任麦克坎特，让他来给我们介绍一下美国有关治疗膝关节疾病的一些技术。赫尔曼西南纪念医院关节治疗中心呢，是休斯顿最大的关节病治疗机构。这里有一整套的关于膝关节治疗的方法。中心每年仅膝关节的治疗手术都要做近3000例。
So arthritis is created by wear and tear, and so normal activities in your daily life can cause wear of the joint over time. The cartilage that lines the end of the bone will wear away just naturally, and so the biggest cause, if you will, or the biggest determinant of how long that knee will last, or how long that cartilage will last in the knee is genetic. And so some patients have knees that will last a lifetime. Some patients have cartilage that will not last a lifetime. So will tend to increase wear and tear as time goes on. It's not necessarily a function of aging per se, but obviously the more time spent on your knees, the more activities done on those knees, that wear and tear will become worse over time. And the vast majority of patients who have arthritis are in their late 50s, 60s, and 70s. So this is a model of a normal knee. Obviously in the knee our cartilage is not blue, but the cartilage that I'm speaking about as far as arthritis is concerned is shown in this model as blue. What we would expect to see is that cartilage is very uniform, that it's very thick, and that throughout the knee it's covering the bone very, very well. What happens many times with arthritis is that instead of that cartilage being nice, smooth, very uniform in appearance, it starts to get areas that are very thin. Adjacent to those very thin areas, there may be areas that are partially thinned out. And so what then happens is that the bone will react, and around the edges of the bone we'll get bone spurs, which the bone spurs themselves are not the problem, but they're an indicator of the problem in that the bone, because it doesn't have the cushion over the top like it's supposed to, will react to the fact that it's bearing forces that it wasn't originally designed to do. So there's multiple treatments for arthritis, and we classify them many times as operative and non-operative. The non-operative treatments that are available for arthritis are medicines that control the inflammation. Arthritis means that the joint is inflamed, and so we can give medicines that will control and help to fight that inflammation. The second is that we can do physical therapy. Physical therapy is aimed at increasing range of motion, increasing strength, so that by doing both of those things we can increase the patient's function. The third thing is injections, and there's multiple types of injections out there. One is a steroid injection, two is a lubricant type injection, and three is either platelet-rich plasma or a stem cell injection, and so those injections can all be tried. It's important that patients understand that none of those treatments will cure the problem. Essentially what we're trying to accomplish with those treatments is to help control the symptoms, and so we're trying to help control swelling, help to make pain better, help to make stiffness better. But since arthritis is the process of cartilage wearing away over time, none of those interventions will regrow the cartilage or change the overall alignment of the knee. Patients sometimes get some benefit from bracing as well. Those braces are designed to try and help maintain or restore more normal alignment in the knee. Once again, the non-operative treatments don't cure the problem, but they're aimed at trying to help make the patient feel better and function better. So that's the non-operative side. The operative side, the only true cure for knee arthritis is a knee replacement, where we take the bad bone and cartilage out of the knee and replace that with metal and plastic. Many times when I'm speaking with patients about arthritis, I talk with them about tires, and I know that seems somewhat silly, but the tires on your vehicle, over time, the tread on those tires will wear away. That's what they're designed to do, and so the cartilage in our joints will many times wear away the same way. I tell patients regularly that you can't rub anything special on the tire, you can't put special air in the tire, you can't put special gas in the vehicle or drive backwards. None of those things will make that tread grow back. And so many times what we're doing is we're taking good care of the tires on the non-operative side. We're trying to, again, control the inflammation, pain, and swelling that goes along with that. We're trying to maintain a healthy weight. We're trying to stay active in order to maintain the health of the joint or that tire. A tire that gets good care, it's rotated regularly, the air pressure is appropriate, and you drive on groomed roads, it lasts longer. Ultimately, when the tire is worn out, the only way to replace that tire is to get a new tire.
麦克的轮胎理论啊，我觉得很有意思。不过提起关节手术呢，确实会让很多人害怕。我呢有一个朋友在中国呢就做过这样的手术，在医院里住了2周，回家以后呢2周还不能下床，1个月后才勉强可以走路。但是呢，麦克却告诉我，他们的手术只需要1天，病人就可以下床走路，当天就可以出院。这对我来说简直是难以相信的神奇。我觉得还是听麦克怎么说吧。
I was used to patients staying in the hospital for 5 to 7 days following the procedure. For the last 7, 8, 9 years, patients have stayed in the hospital for 3 or 4 days. Just recently, in this area, we've decided that we can make that better, and obviously that has changed the stay in the hospital to 1 day. The reason that we're able to accomplish that, again, boils down to pain control and also patient expectations, and so that's part of the reason that the class is very important. The way that we've chosen to deal with pain is, instead of the traditional method of just giving medicines by mouth or giving medicines intravenously, what we're doing now is we're giving, yes, some medicines by mouth, but instead of the traditional pain medicines, we're giving medicines that attack nerve-related pain. We're giving medicines that attack inflammation before even going back to the operating room. The way that we control pain in the leg is many times with a regional anesthetic, where we're numbing the leg so that the brain doesn't perceive that surgery is going on. Therefore, that pathway doesn't get opened up as they go through surgery. In addition, we give injections into the knee during the procedure that help control that pain for 24 hours or so following the procedure. We're giving specific medicines intravenously that help control bleeding. If we control bleeding, we help control swelling. If we help control swelling, then we help control pain. And all of these things end up contributing to the fact that patients have fewer side effects to the traditional way that pain medicines were administered, in addition to the fact the patient is allowed to be more active much quicker and does better. Now the approaches that we use to get down to the bone are through smaller incisions, through a less invasive approach. And so what we're trying to do is create less disruption in the tissues that surround the joint. The point is not necessarily a smaller incision. The point is less damage to surrounding structures. And so what has happened over time is that the instruments that we use to do the procedure have been made smaller. And so the things that we were used to do with certain instruments, because those instruments now are smaller, we're able to do through smaller incisions. There's techniques that have been developed over time that will help us also to approach the joint in a less invasive way. In addition to that, many times patients are sent for preoperative imaging. In my practice, that's done with an MRI. What we do with the MRI is we take an MRI of the leg. We build a computer model of the leg and then a computer model of the knee. We assess the alignment, the rotation, and otherwise, and then our goal is to build parts that we use during that patient's surgery, specifically made for that patient. The goal is to increase the accuracy with which the implants are put in. And so that's another advance that allows us, hopefully, to put things in more accurately than what's been done traditionally. The way that knee replacements have been done traditionally is excellent, and so this is an attempt to just make further refinement on that process and potentially make that even better. So many patients' perception of what a knee replacement involves, they feel like I go in and cut the bone here, I cut the bone here, and that this entire thing gets replaced. In reality, a more appropriate term for this would be a total knee resurfacing. What I'm doing with a knee replacement is I'm removing the blue cartilage and some of the tissue within the joint as well, but much of the patient's bone, ligaments, tendons, etc., stay their own. And so I'm removing what ends up wearing out, which is this blue cartilage in this model. So what we're doing is, if you look at this model here, you can see metal, plastic, and metal. This is put in following surgery. We remove the bad bone and cartilage off the end of the bone. And then after that, we have an implant which is sized and shaped for the patient and then held in place on the end of that bone with cement. So this is on the thigh side of the bone. And then obviously the same thing is done on the top of the shin bone, that we remove the bad bone and cartilage off the top of the shin bone. We replace that with a piece of metal that again is sized and shaped for that patient. And then we put a piece of plastic in the middle that is able to we're able to adjust that size as well, which then allows the knee to function as it was supposed to originally. Many times when I see patients the morning following surgery, they are complaining of a pain level of 0. Whereas before we had made all these changes, patients were in a significant amount of pain the following morning. And so if we control their pain more effectively, obviously we're able to get them up and moving. Many times we get patients up. In fact, it's a requirement that patients get up and walk the day of surgery. In addition to that, since we can accelerate their physical therapy, we can get them out of the hospital typically the next morning. And so patients, instead of staying 3 or 4 days, are now staying 1 day. The vast majority of patients, 98 to 99% of my patients, are going home the following day. And it all boils down to, or it all is based on the fact that we're controlling pain better. After surgery, patients will report that the knee does feel differently. Obviously, the main differences are that the pain is better and that it moves far better than what it was. And so those differences are obviously great. Every once in a while, patients will have the sense that they have a mechanical knee. Obviously, this is metal and plastic, and originally it was cartilage. And so that change sometimes is able to be perceived somewhat. The most common thing that patients will report is that they feel every once in a while some popping in the knee. It's not a painful popping, but they will hear and feel sometimes the fact that they do have metal and plastic in their knee as opposed to their normal God-given cartilage. Many times that feeling is temporary. Patients will feel that typically around 6 to 8 weeks following surgery, and as time goes on, it will become either imperceptible to the patient or it won't bother them any further. And so that typically is something that happens on early in the recovery process, and as time goes on, patients aren't concerned about it whatsoever.
听了麦克的介绍呢，我真的很感慨，科技的发展给人们生活带来了如此大的变化。过去1个月还无法康复，今天却1天就要下地行走。麦克还告诉我，为了帮助病人更好的康复，他们在手术前呢还会有相关的培训，患者的家人朋友可以一起参加，护士呢也一直在陪伴。很多时候病人在自然的生活状态中，不知不觉的已经完成了这个手术。我想呢，所有这些知识对于有关节疾病的华人观众来说都是非常难得的资讯。也可以说是一个彻底康复的机会。那么希望今天的节目呢，能给大家带来帮助。好，感谢观众收看，我们下期节目再见。